Bismillah, Assalamualaikum warahmatullah. You're listening to the immunology lesson. Today we're exploring the foundations of clinical immunology and we'll bring together everything we've learned so far in the context of four areas: hypersensitivity, autoimmunity, and graft and tumor immunology. By the end of this lesson, you'll be able to classify hypersensitivity and autoimmune disorders, explain the immune mechanisms behind grafts and tumors, and recognize patterns of immunodeficiency in disease. Let's go through them one by one. First, we start with hypersensitivity. Type 1 hypersensitivity is what you commonly know as an allergic reaction. So here's how it works. When your immune system encounters an allergen, something harmless like pollen or peanuts, it mistakenly treats it as dangerous. Your body responds by making IgE antibodies, which bind to mast cells. So these mast cells then release chemical mediators such as histamines and leukotrienes, and that immediately triggers symptoms. And these symptoms can range from mild symptoms that can resolve in seconds or minutes, like sneezing or itching. It can range from those mild symptoms all the way to severe life-threatening reactions such as an anaphylactic shock. Type 2 hypersensitivity involves antibodies directly attacking your own cells or tissues. So these antibodies, usually IgG or IgM, bind to specific cell surface antigens. When they bind, they tag or they mark our cells for destruction. This triggers your immune system to activate complement proteins or recruit immune cells that damage your own tissues. So this mechanism is known as ADCC, or antibody-dependent cellular cytotoxicity. Classic examples include incompatible blood transfusions, where your immune system attacks donor red blood cells, or the rhesus factor reactions. By the way, both of these I have explained in earlier episodes or earlier video lessons. Type 3 hypersensitivity is caused by immune complexes. Immune complexes are combinations of antibodies and soluble antigens that circulate in your blood. So these complexes can deposit in your blood vessels or your tissues, and that triggers complement activation and inflammation by recruiting neutrophils. So this inflammation can cause damage that's called vasculitis. A common example for this is serum sickness. This comes from immune complexes from foreign proteins in your medications like serums. It causes things like joint pain, rash, and fever. Type 4 hypersensitivity is different because it doesn't involve antibodies. Instead, it relies on T cells, which is why we call it cell-mediated or delayed type hypersensitivity. Here's how it happens. After exposure to certain antigens, your helper T cells, specifically the Th1 subset and cytotoxic T lymphocytes, they get activated. These cells release cytokines like interferon gamma, and that creates inflammation. But unlike type 1 reactions, this doesn't happen instantly. It takes time, usually around 48 to 72 hours, for it to show symptoms clearly. And examples for this is when people develop contact dermatitis from exposure to substances like nickel in jewelry or poison ivy leaves. Now, let's synthesize what we've learned about these four types of hypersensitivity. Firstly, knowing the mechanism directs therapy or how to treat patients. For instance, antihistamines help with type 1 allergies, but they won't help much in type 4 reactions. Secondly, these mechanisms can overlap in many real-world diseases. Rheumatoid arthritis, for example, involves both type 3 immune complexes and type 4 cell-mediated responses. And thirdly, and this is very important, The damage in these reactions is frequently caused by your immune response rather than by any invading pathogens or allergens themselves. Your immunity, even though it's designed to protect you, can sometimes become the primary cause of harm. Now, let's move on to the next key area, autoimmunity and immunodeficiency. We'll talk about how your immune system normally maintains tolerance to your own tissues and what happens when that tolerance breaks down. Your immune system usually protects you by recognizing foreign invaders without attacking your own cells. So, this ability is called self tolerance. Your body ensures self tolerance through multiple checkpoints. The first checkpoint is central tolerance. So, this happens in your thymus for T cells and bone marrow for your B cells. What happens here is self reactive immune cells are identified and eliminated even before they mature. But some cells still escape from this checkpoint. So your body has another checkpoint, the peripheral tolerance. So this happens in your secondary lymphoid organs like lymph nodes and also throughout your body. And you have regulatory T cells, Tregs, policing and suppressing any self-reactive immune cells that manage to escape that earlier central detection. When both of these checkpoints function well, your immune system stays healthy. But sometimes your self tolerance breaks down, and this can lead to autoimmune diseases. So let's think about how this happens. First, certain genetic backgrounds can make you more susceptible, especially those related to specific HLA alleles. HLA is human leukocyte antigen. Then, environmental triggers come into play. For example, certain infections can cause molecular mimicry. So this means a microbe's proteins closely resembles a protein in your own body. When your immune system attacks the microbe, it accidentally attacks your cells as well. Another important trigger is called bystander inflammation. Here, local inflammation from an infection can unintentionally activate nearby self-reactive immune cells, bystander inflammation. So these triggers, both the genetic and the environmental triggers, they can lead to the breakdown of self-tolerance. So I've made a video on immunotolerance, which I will link in the description. Autoimmune diseases are usually grouped into two main types, organ-specific and systemic. Organ-specific autoimmune diseases affect a single organ or sometimes even a single tissue. Examples include type 1 diabetes, where your immune system targets insulin-producing cells in your pancreas. Another example is Hashimoto's thyroiditis, where your thyroid gland is specifically attacked by your immune system. Systemic autoimmune diseases, on the other hand, they involve multiple organs, multiple tissues throughout your body. Conditions like systemic lupus erythematosus, SLE, and RA, rheumatoid arthritis, fall into this category. They typically involve widespread inflammation and widespread tissue damage, which affect your joints, your skin, your kidneys, and more. While the two types are distinct, the mechanisms causing them often overlap. For example, both types can involve antibody production and can involve T cell activation at the same time. Let's talk about how autoimmune diseases cause the actual damage. We call these the effector mechanisms. One common mechanism involves antibodies, especially in type 2 or type 3 hypersensitivity reactions. So these antibodies can directly target your cells or form immune complexes that deposit in your tissues, causing inflammation. Another important mechanism involves T cells, particularly in type 4 reactions. So for this one, activated T cells directly attack and damage your tissues. In reality, autoimmune diseases often involve multiple mechanisms at once. So your own immune cells and antibodies, their normal reactions spill over and become harmful and cause tissue injury. Now, let's move from autoimmunity to immunodeficiency. Immunodeficiency happens when your immune system fails to protect you sufficiently, meaning it does its job, but not good enough. We categorize immunodeficiencies into two types: primary and secondary immunodeficiencies. Primary immunodeficiencies are genetic, they are congenital defects. This means you're born with them. For example, severe combined immunodeficiency or SCID. SCID is where both B cells and T cells fail to develop properly. On the other hand, secondary immunodeficiencies are acquired later in life. Secondary immunodeficiencies can happen due to, for example, infections or drugs or malnutrition. For instance, HIV infection causes AIDS, which is an acquired immunodeficiency that attacks your immune cells. Knowing that pattern, knowing whether an immunodeficiency is primary or secondary, is important because it helps you understand its prognosis and how best to treat it. Let's now look specifically at B cell immunodeficiencies. When you have a deficiency in B cells, you typically have low immunoglobulin levels. So this leaves you vulnerable to recurrent bacterial infections, especially those caused by pyogenic bacteria, which means bacteria that cause pus formation, like Staphylococcus or Streptococcus. The most common treatment here is immunoglobulin replacement therapy. We call it IVIG or intravenous immunoglobulin. Basically, this involves giving you antibodies harvested from healthy donors. So those antibodies temporarily boost your immune defenses. And this therapy helps prevent infections, but it's not a permanent cure, meaning you need ongoing treatments. It's not a permanent cure. Now, let's focus on immunodeficiencies involving T cells, or those affecting both T cells and B cells together. We call them combined defects. If you have these T cell or combined deficiencies, you're particularly vulnerable to infections by viruses and fungi because fighting these pathogens relies heavily on your cell-mediated immunity. So please watch my previous videos on adaptive immunity if you can't remember what I'm talking about. So yeah, a classic example is DiGeorge syndrome. Here, your thymus doesn't develop properly, so you have fewer mature T cells. Another example is SCID or severe combined immunodeficiency, which I mentioned earlier, where both your T cells and B cells are severely impaired. For many of these cases, one of the main treatment is stem cell rescue or transplant. You replace the defective immune cells with healthy immune cells from a donor. Next, we have complement deficiencies. If you're missing early complement components like C1 or C2 or C4, you have a high risk of developing autoimmune diseases, especially conditions resembling lupus. But if you lose components involved in forming the membrane attack complex or MAC, like proteins C5 to C9, your body will struggle against specific bacterial infections. You're particularly at risk for infections caused by Neisseria species, for example. Doctors typically screen for complement deficiencies using a simple lab test called CH50, which measures the overall activity of your complement system. AIDS is acquired immunodeficiency syndromes. AIDS happens when you're infected with HIV, human immunodeficiency virus. HIV specifically targets and infects your CD4 positive T cells. So these are helper T cells, which is crucial for coordinating your immune responses. As HIV gradually reduces your CD4 positive T cell numbers, your immune system becomes progressively weaker. And then at some point, your body becomes vulnerable to infections that a healthy immune system would normally handle easily. So we call these opportunistic infections. Fortunately, we have effective treatments today called antiretroviral therapy or ART, ART. ART helps control the virus and preserve your immune function. All right, let's now move to the next section, transplantation immunology. Here, we'll think about how your immune system interacts with transplanted organs and tissues, what we call grafts. First, let's talk about genetics and transplantation, specifically HLA matching. HLA stands for human leukocyte antigen. So in previous videos, I taught you about MHC, right? So this is one type of MHC. HLA genes are incredibly diverse. So another way to say that is they are extremely polymorphic. Because of this diversity, the immune system can easily recognize foreign HLA proteins on transplanted tissues. HLA comes in two main classes, class 1 and class 2. Class 1 molecules are found on almost all your cells, while class 2 are primarily found on immune cells. So when surgeons plan an organ transplant, they will carefully match these HLA molecules between the donor and recipient, because better HLA matching means your body is less likely to reject the graft, and then the transplant will likely last longer. Now, let's talk about graft rejection. The first type is called hyperacute rejection. Hyperacute rejection happens very rapidly, within minutes to just hours after the transplant. So why so fast? Because your body already has preformed antibodies against the donor's tissue. So these antibodies usually exist because of previous blood transfusions or pregnancies or prior transplants. When these antibodies encounter the transplanted organ, they immediately attack and trigger severe inflammation and blood clot formation inside the graft. So this causes rapid and often irreversible damage to the new organ. Fortunately, doctors can prevent hyperacute rejection by performing cross-match testing beforehand, before the surgery, to detect these antibodies. Next, we have acute rejection, which typically occurs days to weeks after transplantation. This type of rejection happens when your T cells recognize the transplanted organ as foreign and your T cells attack it. Well, sometimes antibodies play a role here as well, but T cells are often the primary culprits. The good news is that acute rejection is usually reversible, especially if caught early. So doctors can manage it with strong immunosuppressive drugs, such as corticosteroids or other medications that specifically suppress T cell activity. I actually mentioned some of these in the immunotolerance video in previous lessons if you want to check that out. Now, let's move on to chronic rejection. So unlike acute rejection, chronic rejection happens slowly. It can take months to years after the transplantation. This slow rejection is characterized by gradual damage, specifically fibrotic damage, fibrosis, which is scarring of the transplanted organ's blood vessels or the transplanted organ's tissues. So over time, this fibrosis causes the organ to slowly lose function. And unfortunately, from my reading so far, we don't have good treatments yet for chronic rejection. Some treatments might slow down the process, but often they can't fully reverse the damage. Sometimes the transplant itself can attack the recipient. So we call this graft versus host disease. GVHD. So GVHD typically happens after bone marrow or stem cell transplants, where the graft contains active immune cells from the donor, especially T cells. So these donor T cells can recognize your tissues as recipient as foreign, right? And then they start attacking your skin, your liver, and your gut. So these can cause severe symptoms like painful rashes, jaundice, or intense gastrointestinal problems. And doctors usually try to prevent GVHD by giving immunosuppressive medications to kind of calm the donor's immune cells. All right, let's go to our final key area, tumor immunology. We'll explore how your immune system recognizes and responds to cancer cells. First, let's talk about how your immune system recognizes cancer cells. So it does so through tumor antigens. Tumor antigens are proteins expressed by cancer cells. So some of these are called neoantigens, which come from mutations unique to cancer cells. So your immune system can recognize them as foreign. Other tumor antigens are not entirely foreign. They are proteins usually expressed only during early development, like oncofetal antigens or proteins from viruses that can cause certain cancers, like HPV. So these antigens are important targets for your immune response, and scientists are actively studying them to develop targeted cancer therapies. So, how does your immune system fight cancer cells once it recognizes them? Your key weapons here are cytotoxic T lymphocytes, your CD8 positive T cells, and also your natural killer cells or NK cells. CD8 positive T cells directly attack and kill cancer cells when they detect tumor antigens presented on MHC class 1 molecules. NK cells, on the other hand, they identify stressed or abnormal cells. So even those that manage to hide their antigens. Also important are cytokines like interferon gamma. So interferon gamma helps activate macrophages, enhancing the macrophages' ability to attack tumor cells. Generally speaking, tumors with more immune cell infiltration tend to have a better prognosis. What that means is if a tumor has more immune cells inside it, the patient is likely to do better. Unfortunately, cancer cells have evolved clever strategies to evade your immune system. One common trick is downregulating MHC molecules. They reduce the presentation of tumor antigens. When they do that, cancer cells become harder for T cells to detect. Cancer cells also produce immunosuppressive molecules like PDL1. So this is a protein that binds to receptors on T cells and shuts down the T cells' activity. Also, cancers often modify their environment, creating an immunosuppressive stroma. So think of the word stroma as environment. Cancer can create a local environment that weakens immune cells, so your body can't attack the cancer as effectively. There are therapies designed to overcome these immune evasion mechanisms. So one powerful approach is checkpoint blockade therapy. So drugs like anti-PD-1 and anti-CTLA-4 block the inhibitory signals that cancer cells use. So that reactivates your T cells. Another strategy is CAR T cell or chimeric antigen receptor T cells. Here, what doctors do is they genetically engineer your own T cells to recognize specific tumor antigens. So these engineered T cells can then aggressively target and destroy cancer cells. Now, my friends and I work on oncolytic viral therapy. So we are researching how to use viruses like Newcastle disease virus. So we get viruses to attack cancer cells without harming your normal cells. And also we're looking at how to get viruses to stimulate your immune system so it can recognize and attack cancer cells. All right, we've covered a lot. We've learned about 4 interconnected areas of clinical immunology: hypersensitivity, autoimmunity, transplantation, and tumor immunology. If you want to go into research to develop an immunology specialty, this topic and the rest of the course represents your basics. So this is like learning ABC, the basic alphabets of immunology. So you can't stop here, yeah? You need to study deeper than this. However, if you don't plan to go into immunology research, then what I've taught you in all our lessons is more than enough. You can use them to discuss medical decisions with your doctors, for example, and you can use them as starting points to think about your daily health decisions because you now have a good foundation to think about your immune system and your physiological health in general. All right, talk to you next time. Keep on reading, keep on learning. Barakallahu li wa lakum. Wassalamu alaikum wa rahmatullah.